first questions. We will start. Your opinion, sir, had showed that management of heart failure and some WAMI, they have showed that hypertension, hyperkalemia, and the management of this renal impairment. So how you are managing the creat levels or of the potassium levels, how you are starting GDMT in CKD. So we will start, sir, with Dr. N.C. Ambekar, sir, to share his views, and then we will move to Satish K, sir, and the cardiologist. Sir, please.
Good evening. Thank you. Am I audible?
Yes, sir. Yes.
Okay. Good evening, everybody. That's a wonderful lecture by Dr. Shashi Kumar. And thank you, Dr. Komal and Mr. Khare and Mr. Rathod for inviting me for this talk. I have a few interesting comments. Before I answer your question, when Dr. Shashi Kumar mentioned his second line, Dr. Mani had a very interesting comment when he was asked about to talk on cardiorenal syndrome. He said, if you have a patient of cardiorenal syndrome, send him to a nephrologist whom you don't like. Because you will understand that the prognosis of the condition is not very good, and you try to save the kidney, the heart gives trouble, and you try to save the heart, the kidney will get in trouble. Answering your question, I had an opportunity to discuss this issue with Dr. George Bakris. Unfortunately, all of you know that he died about 3 days back. What he was saying was that as you have to monitor the potassium and the creatinine whenever you start. When I asked this question to a couple of other nephrologists, what do you do? Do you start all the drugs at one time, or do you give them a gap? So Dr. Vijay Kher, whom all of you know, he's the senior most nephrologist in Delhi. He was saying that it is better to start one by one. Now, you start with, suppose, an SGLT2 inhibitor first or an ARNI first, and then you start with the other drug after some time. The reason being that sometimes the GFR can drop if you start both of them together. So you have to be a little careful. As far as your question was concerned about the potassium and the creatinine, I think that I agree with Dr. Shashi Kumar that you can give potassium binders, but they are very expensive, and it's not practical to give them because their taste is also, especially of calcium polystyrene resin, is tolerated very poorly. So coming back to the question, as you have to keep a watch, follow up these patients, and don't worry, because one of the senior persons had said that a rise of creatinine after giving any of these drugs is bound to happen. See, if a patient comes in acute decompensated heart failure, you will have to use a diuretic. Now, if he comes and the creatinine rises, which is our type 1 cardiorenal syndrome, even if it rises, one should not immediately worry too much. As long as the rise is less than 30%, it's okay. That is part of the thing. Only thing is when to start these drugs. Now, you could start them, you could start an ARNI probably not immediately during the phase of acute decompensated heart failure, but start it later on and maybe give some gap in between the ARNI, SGLT2 inhibitor, and titrate the drugs according to the potassium and creatinine. But no need to suddenly get worried that the creatinine has gone up or the potassium, even if it is less than 5.5, that is good enough. Because what we are looking at is the long-term benefits of the drug, not at the short-term benefits. That's what I feel about this triple whammy, which you said right now.
Yeah, thanks a lot, sir. So now we will take the opinion of the cardiologist, all esteemed here. So, Dr. Vikash Agarwal, sir, can you please share your views, and then we will take the moderator views, sir. Sir, please.
Yeah, good evening, and I think that was a wonderful lecture, wonderful talk. A lot of insights about how to manage these patients of heart failure. And now with the advancement in therapy in heart failure, now we have multiple drugs. And CKD does complicate matters once you're treating a patient of heart failure. And what the most important concerns are once you're using ARNI or hypotension and hyperkalemia. And once you add MRAs to these patients, again, the incidence of hyperkalemia even rises. So you have to be watchful in these patients. You have to take care of their potassium levels, their creatinine rise. And I think he gave us wonderful insights and wonderful charts about how to, what kind of creatinine rise should be alarming, and a small amount of, or a 30 to 50% creatinine rise should not warrant discontinuation of these drugs, but maybe decreasing the dose, or maybe continuing these drugs is warranted, which a lot of times physicians think, and they stop these drugs. So I think a bump in creatinine should not alarm, and as rightly said, patients should be continued on these drugs. And I think one of the most important things here is that in-hospital initiation of these drugs are now being recommended. I think we have enough data with ARNI use that in-hospital initiation in deserving candidates is important, because this is the time where you can monitor these patients. They are in hospital, you can monitor their potassium levels for a few days. And this is the time when you can guide these patients, teach these patients of heart failure how to go about their monitoring and how to do their follow-ups in the OPD. And this is the time when they are most receptive to how to manage their heart failure. So these are important treatment drugs that we have. All the 4 drugs that we have, ARNIs are important drugs nowadays. We have to use them carefully because of the hyperkalemia and hypotension. We have to keep a watch, but they do produce some remarkable effects in these patients, even in patients with renal dysfunction. So we have to use these drugs a bit cautiously, but all the patients of heart failure do deserve these drugs. Thank you.
Thanks, sir. So, Dr. Satish, I'm requesting your expert moderator comment on this.
Yeah, it was wonderful listening to eminent nephrologist and cardiologist. Like Dr. Ambekar presented from his point of view. So Dr. Agarwal from my point of view, I being a cardiologist. So like both are right from our sides. Dr. Ambekar sir, like there is like now evidence that even in decompensated heart failures, we can initiate ARNIs even in ICU settings. Once in a while we do that. Like Dr. Agarwal suggested, like it's more easier because he is inpatient, we can monitor his potassium. And regarding this hyperkalemia, so hyperkalemia, whether in ICU setting or outpatient setting, like management will differ, definitely. So hyperkalemia in ICU setting, it's very easy for us to manage. So we can increase the diuretic dose, and we can stop mineraloreceptor antagonists, either in outpatient or inpatient. And we can give K binders. As Dr. Ambekar says, though it may not be very palatable, but that is the only option what we have. Like 2 days or 3 days, like potassium comes down significantly, and we may be able to reinitiate therapy in them. And in outpatient setting, what I usually do, like in our heart failure patients, most of them will be on combination of torsemide because it's longer acting than furosemide. But as we know, torsemide has some potassium sparing diuretic effect as well. So what I usually do is I switch them from torsemide to furosemide, so that like potassium is taken care of. And if still not better or potassium is still high, I cut down on the MRAs. Then think of down titrating ARNI. So this is my take on that. Like a difference of opinion is always welcome.
Okay. Thanks a lot. Now I request Dr. Sunil George sir from Kerala, is the senior nephrologist. So the next question is about the dosage, how you are managing in your clinical practice about ARNI when you are initiating in such patients, how you are managing the doses, how you are up titrating. So first we will take the nephrologist opinion, and then we'll take cardio. Sir, please.
Yeah, thank you, ma'am. Before I start, I'd like to point out one thing, because we get a lot of consultations from cardiologists, like a CKD patient, 2, 3, creatinine of 3, 4. They come with an acute MI, and so they have to go ahead and do a angiogram or angioplasty. So many times we tell the patient that it's a contrast-induced nephropathy which can happen to you, and your creatinine, which is 4, can go up to 6, 7. You can become oliguric. You might require dialysis, etc., etc. But as a life-saving measure, we are forced to do a angiogram and an angioplasty. I've seen in a lot of patients, believe me, after the angiogram and the angioplasty, like instead of the creatinine going up, it is coming down. The creatinine, the very next day they recheck, the creatinine from 4 comes down to 3, and further lower down later. And they're discharged with a creatinine of 2, 2.5, etc. So I remember my cardiologist asking me, Dr. Sunil, are you sure this contrast, is it renoprotective or is it nephrotoxic? I tell him, no, it's because the cardiac functions have improved, and because of that, the renal functions are improving. And yeah, this is seen in many patients. I just want to highlight the importance of a good cardiac function, which can definitely improve the renal function. And one more word of we nephrologists, we are a bit reluctant to start ARNIs, MRAs. I mean, it's most of the time it has been started by the cardiologist. And when it comes to a nephrologist, we'll be very cautious. We'll be very cautious of the potassium. We'll be very cautious of the rising creatinine, etc., etc. And our tendency is to bring down the dose of whatever it may be. Nephrologists, we are very comfortable using ARBs. We are very comfortable using SGLT2 inhibitors, etc., etc. But when it comes to MRA, like everyone is very fond of using finerenone, the Kerendia molecule, as you all know. But then my couple of patients, they had very bad hyperkalemia. Here, I'm very happy to note that we nephrologists, we tend to write a lot of ARBs. I mean, we write a lot, left, right. And hyperkalemia is a risk for that also. But then I'd like to convey a message that we have seen in all the studies, when we combine it with an ARNI, the risk of hyperkalemia is less. So that is a very good point we have to keep in mind. And in those patients whom we write valsartan, we should always, especially when there's associated cardiac failure or patients, diabetic patients, even if they don't have a cardiac problem now, in future also, they can definitely go into a cardiorenal or renocardiac syndrome. So it's always better to try ARNI. And you ask me about the dose, I'll start with the low dose, maybe 50. And then depending on the creatinine, the potassium, etc., we tend to step up the dose. So this is what we nephrologists, we feel.
Thanks, sir. Now we will take the opinion of our cardiologist, Dr. Anup Agarwal, sir, is here. So, sir, your opinion about using this drug, especially SGLT2 inhibitors, Dr. Shashi Kumar highlighted across the spectrum its use. What's your experience, sir? Can you please share your views?
So, SGLT2 inhibitors have basically become a cardiology drug now. It is no more an endocrinology drug, and it is a standard of care across all the spectrum of heart failure. In fact, it's the only drug which gets a class 1 recommendation across the entire spectrum of heart failure. So we are, I think the resistance of prescribing SGLT2 inhibitor is less and less now. We are almost universally prescribing in all our patients who have heart failure. As far as ARNI are concerned, and I think we have enough data now that we can't ignore this molecule over the traditional ACE inhibitor and ARBs. So when we have concomitant patient with CKD, I think SGLT2 inhibitor becomes a little bit more challenging because the efficacy goes down. So patients who have got GFR of less than 30, I don't even try. I know we can try, we can see how it goes and all that, but I personally don't use it. Same thing is with ARNI, but ARNI, I'm a little bit more liberal with that. But I'm not sure what my nephrologist's criteria would be, but I still stick to the GFR of 30. So when GFR is below 30, then I'm co-managing very closely with my nephrology colleagues. When the GFR is more than 30, then I'm quite comfortable initiating as well as up titrating these drugs. I see my patients more frequently in my OPDs, so I am very closely monitoring their potassium level, their rise in creatinine and all those things. But because here we are dealing with a cardiac substrate, I'm not that worried about it. Giving it in a CKD predominant subset, I don't know what my nephrology colleagues would feel. I personally do not initiate. I always follow what my colleagues would say in a CKD dominant pathology. But when there is a cardiac dominant pathology with a cardiorenal syndrome or a chronic CKD concomitant to that, till the time GFR is more than 30, it's okay with me. Not an issue at all.
Thanks, sir. We will take the opinions of Dr. Shashi Kumar. You would like to add, and then we'll move to our.
For nephrology point of view, so I'm quite comfortable of using this ARNI in those patients, those who have GFR of more than 60, or those patients who are end-stage renal disease, having heart failure, and especially with no urine output, because I have nothing to lose. I have no GFR to lose. I have less risk of hyperkalemia. And heart failure incidence of in end-stage renal disease patient is quite high, maybe up to 60%. So I'm quite comfortable of using this molecule in my dialysis patients. But in between subsets, those patients whose GFR is between 30 to 60 and 30 to 50. So in 30 to 60, I use this molecule with monitoring. 30 to 15 is that subset where I'm really worried to use this molecule. SGLT inhibitors, as already mentioned, it's a drug of choice for a spectrum of heart failure. Even in fact, this is the class 1A recommendations for use in HFpEF patients. So I would like to use SGLT inhibitor first in those patients. But as I said, today's till date recommendation, we can use GFR up to 20, but we have studies in pipeline. And recently I saw the KI reports where they are using this molecule in end-stage renal disease patient as well as SGLT inhibitors. So in advanced renal failure, not on dialysis, I am quite worried, and I'll monitor the serum creatinine and serum potassium.
We request nephrologist view on this up to what eGFR, sir. Your views, Dr. Ambedkar and Dr. George, sir.
Dr. Ambedkar first.
Yeah, as far as the ARNI is concerned, I think it's a drug which has proven its efficacy as a pillar of treatment of heart failure. So I would start with a dose of something like 25 milligram twice a day. Perhaps I would not use it in a very low GFR, but in a where there is even above 60, I don't think there is any problem. 30 to 60 also I would start. And as I said, these patients require monitoring. So probably you would call the patient to your clinic maybe once a week or twice a week. If you are sure of that follow-up, there is no harm in starting with a lower dose. Also, you go from 25 to 25, say twice a day, to 50 twice a day, and step it up as depending upon what the potassium. And I agree with Dr. George. Dr. Kripalani, you must have heard of him as a nephrologist. एक बार उन्होंने हिंदी में बताया, हार्ट अगर बचा ना हो तो किडनी गया खड्डे में. That is a little bit of a harsh statement for nephrologists, but it concurs with what you said, that even if the patient requires dialysis, you have that facility. एक बार हार्ट ने तकलीफ दिया तो फिर मुश्किल हो जाता है. Everything becomes very difficult after that. And we have all seen sudden cardiac deaths occurring in patients who are having stable renal function, and then you run a big risk. Because if you try and understand type 2 diabetes, the cardiac disease is there when the patient is diagnosed to have type 2 diabetes. So the cardiac disease is already there. So if you don't tackle it in time, it's going to lead to a lot of trouble later on.
Yeah, I like to add on that it's not just to control the blood pressure. See, we have to prevent the progression of renal failure. That's also very important. As a nephrologist, our main duty is to prevent and we don't have many drugs in our armamentarium to prevent the progression of chronic kidney disease. And as all the panelists have mentioned, all the benefits and GFR, etc., we have to keep in mind this can help in ARNI can definitely also help in preventing the progression of renal failure also. So that's one more point I'd like to add.
Thanks, sir. Sir, expert comments from our esteemed moderator. Dr. Satish K, sir, your views on this?
Yeah, I agree with most of the views. Like regarding renoprotection with respect to ARNI, there is still some debate. So it is still not proven beyond doubt that ARNI is going to help prevent decrease of eGFRs. So that is still debatable. But rest of the things, I definitely agree with everyone.
Sir, we will take one last question from the audiences. I'll request our nephrologist, Dr. Ambekar, sir, that role of sacubitril valsartan in resistant hypertension. Is there any role of this molecule apart from HF? Can you highlight your views on this?
Yeah, recent studies have demonstrated that, as you know, 3 drugs, including one diuretic, is especially one MRA, would be probably helpful in treating resistant hypertension. But the recent studies have also shown that ARNIs play a very important role in the treatment, and I think it's probably one of the drugs which should now be included in the treatment of resistant hypertension. Probably, of course, some of the studies are still going on, but definitely there are more pointers that it should be used as a treatment for resistant hypertension, because especially I'm sure Dr. George will agree, sometimes in chronic kidney disease, hypertension becomes a real major issue. And in those, even with borderline creatinine, you would find that these patients have blood pressures which are very difficult to manage. Just to give you an idea, any diabetic patients with chronic kidney disease and hypertension, probably you would require 3.5 types of, and not drugs, not tablets, but 3.5 types of antihypertensives to control the blood pressure. So probably with a little bit of caution, these drugs can be used, and they should be used probably right now.
Thanks, sir. Any other expert panelists would like to add on this point about the resistant hypertension's use?
Yeah.
Yes, sir.
Yeah. Resistant hypertension is very difficult to manage. Like as Dr. Ambekar sir says, like in CKD, resistant hypertension is very much there. But very often what we see in our practice, like it is most of the time it's because of non-compliance. So having ruled out non-compliance and other things, definitely CKD and ARNI in most of the trials or almost all the trials, like during the run-in phase, like most of them had withdrawn close to 10% in Paradigm and many of the other trials as well because of hypotension and other reasons. So definitely it's a good antihypertensive, but still there are no definite data regarding ARNI in resistant hypertension. If something is not controlled with other drugs, you can try it as another molecule as of now.
Thanks a lot, sir. Yeah, sir.
I have a question to the Dr. Satish. What is your take on vericiguat and treatment of anemia? Are they still one of the pillars of are they included or going to be included as the pillars of treatment of heart failure? Because as of now, everyone treats it, but what is your take on that?
So vericiguat and anemia, different thing, or as a complication of vericiguat anemia, sir? Like what you meant?
I mean, vericiguat are different. They would.
Okay. Okay.
What
sir.
is your take on these?
Yeah, Victoria trial, like that vericiguat trial, what you are talking of, came like maybe 3 or 4 years back. That vericiguat has not taken over the market like what ARNIs have taken over. And only indication for vericiguat in our practice is like if someone has recurrent heart failure on GDMT, EF being less than 45%. So, and recurrent hospitalization for heart failure. So this has not come into the foundational therapy, as we all know, like 4 drugs. So vericiguat is not a foundational therapy yet. So it is like, I myself have not used vericiguat so far in my practice. And anemia definitely is one of the adverse effect of vericiguat. And if we have to discuss anemia and heart failure, Again, it's a very big topic, sir. Like we look at iron profile, transferrin saturations, we look at ferritin. Like if I had to like briefly tell about that, I very often look at iron deficiency in my heart failure patients without anemia. So that is like functional iron deficiency and absolute iron deficiency. Like if someone's ferritin is less than 100, so directly we take it as absolute iron deficiency and I correct that iron with IV carboxymaltose. And if ferritin is between 100 to 300, I look at TSAT, transferrin saturation. If it is less than 20%, then that is taken as functional iron deficiency. And definitely I'm going to correct both of these. And regarding the dose, it depends on what is the baseline hemoglobin, whether I'm going to give 500 mg or 1 gram or even 1.5 grams. And definitely, like in the trials, it has shown that iron deficiency correction with IV has shown improvement in 6-minute walk distance, their quality of life and other things. So though not like with mortality, but what we always say is quality is as important as quantity with respect to life. In brief, this is my take on that.